at least a 3-generation pedigree with all of the cancer incidences, age onset, and whether these patients are alive. And then depending on the clinical scenario, either single-site testing, if there's a mutation, a known mutation in the family, or multi-site testing, or comprehensive BRCA testing, or now, new hereditary cancer panels are discussed and tested. And we've received the results back in about 2 to 3 weeks. I would like to talk a little bit about the management once we have positive test results, and I will focus on the person with cancer and not on the healthy individuals, because Dr. Pujol will talk about that in this morning's session. Because women with breast cancer and the BRCA mutation still are at increased risk for contralateral breast cancer, that has prospectively been reported in at least 2 major studies, one from North America and one from Europe, and the risk is 65%. Discussing upfront bilateral mastectomies is very helpful. This does not mean, though, that segmental mastectomy for the affected site, a unilateral mastectomy, is not an option. So that's an option as well. Or a patient, because of the increased contralateral breast cancer risk, might opt, after discussion with the surgeon, for bilateral mastectomies, the opposite side being preventive mastectomies. And also, because of the risk of ovarian cancer that is up to 40–50% in these individuals, we discuss with our patients bilateral salpingo-oophorectomies and refer them to our gynecology oncology colleagues in our center. While bilateral salpingo-oophorectomy reduces ovarian cancer risk by more than 90%, if in some instances the patient had an ER-positive tumor and undergoes oophorectomy and was premenopausal at the time of diagnosis but became then postmenopausal, the treatment implications for that might be that instead of tamoxifen, the patient could be offered an aromatase inhibitor. Otherwise, she would have offered tamoxifen because she was premenopausal. So if patients for some other medical reasons or preventive reasons undergo salpingo-oophorectomy, become menopausal, then in this BRCA mutation carrier, we might offer an aromatase inhibitor even though she's young. The other implications in terms of management, medical management for an affected person could be discussed in the adjuvant-neoadjuvant setting or in the setting of metastatic disease. And as you know, there are now new approaches, which is not the topic of today's talk, but that includes treatments and studies with platinums, and especially PARP inhibitors. So I want to give a brief example about the neoadjuvant treatment that we have undertaken at our institution. We looked at about 300 women who underwent BRCA testing at our institution, but these patients were also treated with neoadjuvant systemic therapy. In this group, we had a 25% BRCA positivity rate, and our treatment was pretty homogeneous within the BRCA positive and negative group as a single institution experience. And about 90% or so of our patients received an taxane plus anthracycline in the neoadjuvant setting, and only a minority received only an anthracycline and did not receive the taxane. And I think there was only one patient who received taxane only. She received TC, but that was only one patient. Again, because of the interest, I am only summarizing some of the significant results. When we looked at factors that predictive pathologic response, besides ER status being ER negative, produces a higher PCR rate. Use of trastuzumab, obviously, as we know and expect, produces a higher PCR. But what we've also seen is that having a BRCA1 mutation versus having no mutation also induced a higher PCR. So achieving a PCR was actually 3 times more likely in women with the BRCA1 mutation compared to non-carriers. And we also wanted to look at the survival outcomes in this patient population. So in this, and I don't know if you can see it here, in panel A and B, we are looking at the recurrence-free and then the overall survival divided by BRCA status. So it appears that actually that in terms of disease-free survival, as I mentioned in the previous slide, BRCA1 mutation carriers have a higher disease-free survival. They also had a higher PCR rate compared to negative. However, when we looked at overall survival, that difference we did not see. When we then, in panel C and D, look at recurrence-free survival and overall survival divided by PCR versus no, as you can see, having a PCR, obviously, versus no PCR improves disease-free and also overall survival significantly. We and others have reported this repeatedly in other cohorts as well. So it was good to see that this small cohort in 300 patients represents, again, what we see in the literature. Then in panel E and F, we are looking at the disease-free and overall survival divided by triple negative versus non-triple negative. And as expected, again, the disease-free and overall survival is actually worse for the triple negatives versus non-triple negative patients. I wanted to do further subgroup analysis, but the statisticians stopped me because they said that the numbers would be getting really smaller. But I think collectively in prospective trials with multi-institutional trials, we can actually answer and look at some subgroups also in terms of survival. The second part I mentioned a minute ago, the medical implications a BRCA testing could have for the affected person is, in the metastatic setting especially, whether it would open the doors to new and novel treatments, targeted therapies such as PARP inhibitors. Very briefly, what is PARP and PARP inhibitor? So the poly-ATP ribose polymerase is a regulator of DNA damage repair process, as you know. It's involved in the DNA base excision repair, and what it does, it binds directly to the area of the DNA damage, and then it produces these chains of proteins, the branched proteins, and what these do then, these attract the other effectors and repair proteins that is required for the base excess repair process. And furthermore, there is a lot of information in literature, and this is just one small example, showing that BRCA deficient cells are very sensitive to PARP inhibition, especially in higher concentrations. So it appears that BRCA deficient cells are really good targets for PARP inhibitor therapy because they already have a DNA repair defect. And just to summarize for the interest of time, here I'm showing you phase 1 and phase 2 studies that have been done and completed in either BRCA mutation carriers. In some studies, triple negativity rate was reported as well, with different PARP inhibitors such as olaparib in a phase 1 study, or olaparib in a phase 2 study, or ABT888, which is another oral PARP inhibitor in combination with temozolomide. And you can see here the response rate or clinical benefit rate ranges anywhere from 37% to 60%. And in fact, in this single agent phase 2 study, in women with BRCA mutations, advanced metastatic breast cancer, who received prior chemotherapies, the response rate was 41%. We actually participated in that study, and the side effects were only grade 1 to 2 that were all reversible when the drug was stopped, so we were able to restart the drug. So there's a lot of activity and a lot of excitement in phase 2 and phase 3, single agent or combination studies with chemotherapies is currently ongoing. So stay tuned for the PARP inhibitor story. One aspect I mentioned at the beginning, which is important for us to really make an impact in the general population, is to identify a mutation in the person with cancer. But then, when we have that information, reach out to the family and tell the patient to hopefully tell her family members that she has a BRCA mutation, and that first-degree relatives, regardless of sex, male or female, have a 50% risk of carrying the mutation. That also includes the children, as well as paternal or maternal side, mother or father, depending on from where it comes. So ideally, if a person shares that information, the affected, especially first-degree relatives who have a 50% chance of having a mutation should be tested. And I had shown you in previous slides that the Markov modeling, if they get tested and do appropriate screening and risk reduction management, they will reduce their breast cancer and ovarian cancer risk significantly. And as I mentioned, Dr. Pujol will be then discussing screening, medical prevention, and preventive surgeries in the next session. And very briefly, it's a very hot topic. It's being debated, and I will not be able to give you any answers, just a little bit insight that it's going on. Next generation sequencing panels for hereditary cancer is now happening. The use of next generation sequencing technology allows for testing many genes at the same time, at the same cost, where we would be testing these genes one by one individually. So BRCA1, if it's negative, then we go to P53, then maybe to P10, and each test is about $2,000, $3,000. In this panel, you can do everything together for the same price. And several well-established clinical and genetic testing labs are now offering these panels. But, however, they are offered either as a kitchen sink approach, where any gene, 50, 70 genes are put in, and you might not need these genes, or they are specific, particularly for some cancer types, or they don't focus on cancer types, but only focus on high penetrant genes. I have only two slides, and I can tell you, and the other one is the conclusion. I did not do this, they stopped it. One panel, for example, has all of the genes. I was just giving an example of it's Embry Genetics or Myriad Genetics. They are now the Embry Genetics and the Myriad Genetics example. There are 5 other companies that are offering all of these genes. It will be then up to us if we want to use these panels. So basically, in conclusion, I think there's a lot going on right now in the area of genetic risk assessment and testing. It is very important to integrate that into breast cancer management. It's very important to outreach to family members. And with the next generation sequencing, I think we will have our hands full to analyze the results of these testings if we find, for example, unexpected genetic mutations. Thank you very much.